Bismillahirrahmanirrahim. Welcome to the channel. In today's discussion, we will try to cover the important topic from the oropharynx, that is about oropharyngeal tumors. Uh, you are requested to like, share, and subscribe the channel so that future ventures you are not going to miss. We know that the pharynx is divided into three parts. The most superior part or upper part, it is called nasopharynx, then is oropharynx, below is the hypopharynx. Then front is the oral cavity, and posterior continuation of this oral cavity, this is called as oropharynx, which is in continuation with the nasopharynx above and the laryngopharynx below, and extends from the level of the hard palate, not the soft palate, because when we have to give some anatomical reference points, these should be some bony parts or hard ones, so that they should not be moving uh, with the movements of swallowing, respiration, etc. So same is the case here. So the level of the hard palate, if we draw the line posteriorly, so that is the superior boundary of the oropharynx, and it goes below up to the level of the hide bone. So from the level of the hard palate above and the level of the hide bone below, this is the area which we call as oropharynx. Tumors, as we know, anywhere in the body, these are the abnormal growths of the tissue, and in the region of the oropharynx, same is the case as elsewhere in the body. So these can be malignant and benign tumors. A benign tumor is a mass of cell that lacks the ability to invade neighboring tissues or metastasize, and these characteristics are required for a tumor to be defined as cancerous, and therefore benign tumors, they are usually non-cancerous. As far as the benign tumors of the oropharynx are concerned, number of benign tumors can occur there. One is papilloma. Papilloma, it is usually asymptomatic, and surgical excision is the treatment of choice for papilloma. Hemangiomas may be capillary or cavernous, and their treatment is diathermy coagulation or injection of the sclerosing agents. Cryotherapy or laser coagulation may also be effective. Pleomorphic adenoma, these are mostly seen submucosally in the hard palate or in the soft palate, as you can see in this picture as well, that the overlying mucosa is intact. So submucosally these are present, and these are potentially malignant, so they should be excised totally. Mucus cysts, they are usually seen in the vallicula, and surgical excision is the treatment of choice in case of symptomatic cysts. Here you can see this is the tip of the epiglottis. On the sides you can see this is the piriform fossa. This is the base of the tongue, and this in the midline is the median glossoepiglottic fold, while laterally is the lateral glossoepiglottic folds. So there are two glossoepiglottic folds and one median glossoepiglottic folds. So in total there are three glossoepiglottic folds, and there is cup-shaped cavity present there between the this epiglottis and the base of the tongue, which we call as vallicula, and here you can see a mucus cyst, it is there. Then fibroma, lipoma, they can also occur there in the oropharynx. As far as malignancy is concerned, the risk factors are the predisposing factors. Just like anywhere in the head and neck carcinomas, smoking is the major risk factor, and it is observed that more than 80% of the oropharyngeal cancer patients, they use tobacco, and your risk increases the more you smoke. Then some researchers, they estimate that 70% of the oropharyngeal cancer patients, they are heavy drinkers. Eating a diet which is low in vegetable and fruits is also a risk factor. And head and neck cancer, as elsewhere this squamous cell carcinoma, it is more common in males as compared to females, so same principle applies here. Then it is observed that being infected with the human papilloma virus, HPV, especially number 16, a virus that is transmitted through sexual contact, and more than 90% of all HPV related oropharyngeal cancers. It confers 14-fold increase in risk for oropharyngeal cancer. Double stranded DNA virus, this is with more than 120 strains, and most common which are high risk, they are types 6, 11, 16 and 18, and out of these 16 is the most notorious. And this is in human tumors it is being seen. So HPV genome, it encodes three oncoproteins, that is E5, E6 and E7. In addition to the regulatory genes, that is E1 and E2, as well as capsid proteins L1 and L2. Histologically, squamous cell carcinoma is the most common, just like anywhere else in the head and neck. So same is the case in oropharyngeal carcinoma, that exclusively in more than 90% of the cases squamous cell carcinoma is the most common one, and 60% is moderately differentiated, while 20% is either well differentiated or poorly differentiated. Its variants are spindle cell, which resembles a sarcoma, and basiloid, which is more aggressive in behavior and poor clinical outcome. In addition to squamous cell carcinoma, we know that there is abundant lymphoid tissue in head and neck. So both types of lymphomas, either Hodgkin or non-Hodgkin, can occur in the oropharynx, and 90% of the lymphomas, they involve the lateral wall of the oropharynx. In the lateral wall of the oropharynx, we know that there are either palatine tonsils or anterior and posterior fascial pillars, and in 10% of the cases it may involve the base of the tongue. Then soft palate, we know that there are scattered minor salivary glands are there over the soft palate, so the tumors of the minor salivary glands can also occur there, which may include lymphoepithelioma, adenocarcinoma, then malignant melanoma, sarcomas and plasmacytomas can also occur there. Gross appearance of malignancy may differ from person to person. It may be exophytic type or superficially spreading, are ulcerative type, are infiltrative type. So any of the presentation on gross appearance may be there. As you can see here, this tumor is presenting, exophytic type of tumor is there. In squamous cell carcinoma, the common sites of the malignancy in oropharyngeal, in order of frequency, they are involved. In 60% of the cases, this is the lateral wall, which includes tonsil and tonsillar fossa. Base of the tongue is involved in 25%. 10% of the squamous cell carcinoma tumors, they will involve the palatine arch. Palatine arch is nothing but it includes the soft palate, uvula and anterior pillars. And then in 5% of the cases, the posterior pharyngeal wall may be involved. You can see a tumor which is involving the lateral wall of the oropharynx. This tumor can spread locally, and this direct extension, it may invade the vallicula and the larynx, parapharyngeal area, and into the medial pterygoid and lateral pterygoid muscles and pterygoid plates. If it goes upwards, it may involve the nasopharynx, and forward extension may involve the oral tongue, because base of the tongue is involved in oropharynx, while anterior two-thirds of the tongue is included in the oral cavity, which is called as oral tongue or anterior two-thirds of the tongue, and it can involve the retromolar trigone as well. Perineural invasion can involve cranial nerve number 5 and 7. Then a submucosal extension It can be visualized as erythematous regions without distinct borders or ulceration. In 55% of the cases, there can be lymphatic spread, and in 20% of the cases, there can be hematogenous spread, that is distant metastasis. In 55% of the cases, the lymphatic spread is there, and most common location of the lymph nodes metastasis from the oropharyngeal cancer is ipsilateral level 2. Ipsilateral, on the same side, level 2. This is the first echelon of the lymph nodes which is involved, that is the upper deep cervical or upper jugular chain. Then mid cervical, that is level 3, and then level 4, that is the lower cervical lymph nodes. Contralateral lymph nodes, they are at risk for the tumors which are near the midline or advanced T and N stage already. Skip metastasis is very rare, only 0.3% is quoted in the books about skip metastasis in oropharyngeal cancers, while level 1 and level 5 lymph nodes, they are usually associated with involvement of the other lymph nodes. So other lymph nodes will be involved, and then followed by the involvement of level 1 and level 5 lymph nodes. Distant metastasis, as I just mentioned, that it is seen in patients with advanced stage diseases, and the most common site of hematogenous metastasis is the lungs, and it is seen in 20% of the cases. However, primary lung cancer should always be excluded. Now, oropharyngeal carcinoma, it can present as a lymph node or lump neck, which is asymptomatic. The patient may present with the only complaint that there is a swelling in the neck or there is a lump in the neck, and there may not be any other symptoms. So asymptomatic neck node or neck mass, then the patient may be having pain in the throat, dysphagia, there can be referred otalgia, there can be foreign body sensation in the throat, patient can present with hemoptysis, there can be weight loss, and when larynx is involved, the patient may present with voice changes. So there can be only lump neck, and there can be variety of other symptoms also present there. Now, diagnostic workup is just like the workup for any other patient suspected having malignancy in the body. So a detailed history and detailed journal physical and clinical examination and ENT examination, of course, and this should also include the lymph node examination, that is for the neck. So inspection, palpation should be done. Then indirect laryngoscopic examination is very essential. Fiber optic examination can also be done in the clinics, and even if in doubt, we can go for direct laryngoscopy, which can be done under general anesthesia. Then laboratory tests, we have to go for journal workup and journal health status of the patient before embarking upon the treatment for any malignancy. So similarly, the laboratory tests will include the CBC, then blood chemistry of the patient. We should have a baseline investigations for renal function tests, for liver function tests, then diabetic status. Then HPV should be tested in a biopsy specimen, because as we have seen in the etiological factors or the risk factors, that HPV 16 is the main culprit. Then screening for hepatitis C virus and hepatitis B virus is essential. Biopsy, of course, of the tumor or the mass or from any suspected area will confirm our diagnosis. We can request for ultrasonography of the neck to see the lymph node involvement or lymph node presence there, or the extent of the tumor as well can be assessed. Then if any lump neck, as we have seen in the clinical features, that the patient may be having only symptom which is a lump neck. So FNAC of that lump neck should be there to confirm that whether it is an inflammatory lymph node or it is a metastatic lymph node. And once it is established that that is a metastatic lymph node, then we have to go for primary tumor. So for that we can go for pan endoscopy. When I say pan endoscopy, it includes the nasopharyngoscopy, direct laryngoscopy, bronchoscopy and esophagoscopy because of the risk of second primary in upper digestive tract. Then ECG, because if the patient has to be subjected for further treatment in future, the heart status or baseline ECG should be there with us. In radiological investigations, we can start from the simple x-rays, and these may include chest x-ray to rule out the metastasis, distant metastasis in the lungs, because lungs is the one organ which is usually involved in hematogenous spread. Plain radiograph of the neck or the mandible may show us the tumor invasion, or then we can go for contrast enhancement CT scan from base of the skull to T4. So whole neck and the mediastinum should be included, or we can go for MRI, or even we can consider about the PET scan. So high dose contrast enhanced computed tomography, that is CECT, from base of skull to T4 with the ipamidol is the contrast material which is used. It will show us the extent of primary tumor, then evaluation of the lymph node status, evaluating the involvement of the mandible or skull base, extracapsular extension with irregular nodal margin without clear distinction with surrounding fat, or when there is thickening of the surrounding fibroadipose tissue or the muscles, and then subcapsular spread is often difficult to characterize with CT scan. MRI, as we know, it is superior to CT in specific situations, including delineating orbital or skull base involvement and defining intracranial perineural tumor spread. But it has got a better ability to identify subtle soft tissue involvement by the tumor, deep osseous invasion and marrow replacement. Perineural spread of the disease can be assessed with MRI, and extent of anterior spread of base of tongue tumors. PET scan, that is positron emission tomography, its sensitivity is 100% while its specificity is 60% for pathological proven tumors, but its ability to detect the occult pathological cervical lymph nodes is far better than normal CT scan. For example, in this picture on the left side you can see a CT scan, normal CT scan, and here we are not sure about the lymph node involvement. But if we go on the right side, the PET scan, then you can see very clearly it is showing the lymph node involvement on this side. So that is the importance of PET scan. This is a table which is showing us the incidence of clinically lymph node metastasis percentage according to the stage of the disease, and you can see in T3 and T4 the lymph node metastasis involvement is high as compared to T1. But in base of tongue you can see even if the tumor is at T1 stage, still 70% chances are there of the lymph node metastasis in base of the tongue. Now this is the TNM classification, because before embarking upon for the management plan for any malignancy, we have to stage the disease, and for the staging of the disease we should know the tumor, the lymph node status and distant metastasis, and that's what we call as T and M. T is for the tumor, N is for the lymph nodes, and M is distant metastasis. So T is just like anywhere else in the head and neck, that T1 is when tumor size is 2 centimeter or less, T2 is tumor size more than 2 but less than 4, T3 is tumor is more than 4 centimeter in greatest dimension, and T4A is when the tumor is loco-regional advanced tumor and direct spread is there, and it is involving the larynx, deep extrinsic muscles of the tongue, medial pterygoid, hard palate or mandible, then we label it as 4A. And T4B is when tumor invades the lateral pterygoid muscles, pterygoid plate, lateral nasopharynx or skull base, or in cases the carotid artery. The lymph node staging is just like lymph node staging anywhere else in the head and neck tumors. So you can check it out from your book. This is the same. Distant metastasis, M0 when no distant metastasis, and M1 when there is distant metastasis. And in case of oropharyngeal carcinoma, we just saw that 20% of the cases at the time of presentation will be having distant metastasis, and lung is the most commonly involved organ. So this is the staging of the tumor. When any T or any N, but with M1, it is straight stage 4C. Otherwise, in rest of all is M0, and stage 1 will be of course T1, but there will be no lymph node metastasis and though no distant metastasis. Stage 2 will be T2 tumor locally, but again the N0 M0. Stage 3 is T3 with N0 or M0, or it may be T1 or T2 or T3, any T from number 1 to 3, but N1 is there. And stage 4A will be T4A with N0 or N1 and M0, and T1 to T4A. So any T up to 4A with N2, it is 4A. But if it is T4B with any N, or it is any T with N3, that is stage 4B. And with any T, any N with M1, that is stage 4C. T4A, first they thought it is resectable, and T4B it was considered as unresectable. In 7th edition, this American Joint Committee, it has established that T4A is moderately advanced local disease and T4B is very advanced local disease. And stage at the diagnosis, you can see it is oropharyngeal cancers, they are usually diagnosed at a late stage. You can see more than 60% of the cases will be diagnosed and they will be at stage 4 at the time of presentation. Only 1.7% can be diagnosed at stage 1. So with that, we come to the end of today's discussion. You are requested to like, comment and share the channel, and don't forget to subscribe the channel. Thanks for watching.